Well, good afternoon, everybody. My name is Chad Stage, and I'm the Behavioral Health Manager here at Northwest Community Care. And with me is Mr. Jim Sacco, who is a certified MINT trainer based out of Atlanta. And today we are going to be covering a topic that, in the work that Jim has done with our care managers over the past year, has come up quite a bit as a concern and sort of a problem area for a lot of the care managers on how to work with these types of patients, and that is patients who have personality disorders. So Jim is going to walk us through each sort of specific personality disorder and hopefully give us some good advice on how to maybe identify some of those diagnoses and also how to approach and deal with those types of patients. There is a chat option due to the number of people that are in this webinar. We have muted everyone because that could become very chaotic. So there's a chat box below that you can send messages or questions to Jim, myself, or to the entire group. And then also at the end, we're going to address those questions. We won't be doing them sort of in real time. We'll have a period of time toward the end of the presentation where we're going to be addressing those questions. So without further ado, I give you Mr. Jim Sacco.
Great. Thank you, Chad. Good afternoon, everybody. Thanks for making time. It's great to have so many people who are doing their lunch and participating. What I would say is I'm not in an hour going to make anybody a psychiatrist or a psychiatric nurse. When Chad and I were when I was last at CCNC headquarters in Raleigh, Amelia Mahan, most of you know Amelia, many of you know of Amelia, who's the behavioral health person at headquarters, said that they'd just done some look back at their case management statistics, and not surprising probably to anybody on this call, the figure comes in at just 50%, just half of all enrolled participants had behavioral health as part of the picture, that it's about 50-50. And so it just reinforced what I've been doing with the folks in Winston and with the MI champions, that there's a huge need for all of us, again, not to necessarily manage or treat the behavioral health disorders, but to have some ability to screen. And really for this webinar, the point is to help people conserve resources. That honestly, if I were to say what my goal is, it's to recognize the seriousness of these disorders, to give care managers permission to practice some good self-care, and to really limit how disruptive these really challenging consumers are. So Chad said my name, there it is there. My parents bought a master's degree in social work. I always give them credit. I've been involved in CCNC, for those of you who don't know me. We've got a number of you from CC Northwest, but a number of people I'm seeing Cape Fear and Duke and other places. So for those of you who aren't as familiar, we sent this out across the system rather late yesterday. I have a role in helping CCNC roll out motivational interviewing. I was one of the initial trainers when the AHEC team took over, gosh, 4 or 5 years ago now, I guess. I was lucky enough to be up in Shelby and Asheville in the first round of frontline training. I've continued through various iterations of new hire training. I'm a mentor to the MI champions across the state, and I have the privilege of working in the network in Winston and also in Greensboro, and providing ongoing coaching to those people. So what I wanted to do is kind of talk about how we got here. Again, when I have listened, again, part of my role in the coaching is to say what are your challenges, what makes this work difficult. So many of the challenging consumers that people face in CCNC everywhere is serious mental illness, untreated addiction, and again, personality disorders, I think, being among the most challenging. I took this back to my champions and said, wow, they got a lot of really serious mental health problems in Winston-Salem, and multiple champions in the system said, oh, it's not just Winston-Salem, it's everywhere. And so it became a need that emerged. Part of what, frankly, happens is for people who aren't aware, there can be a way in which care managers engage in ways that may not be helpful to consumers, but also that are depleting their energy. We had a session in Winston late last year in which people talked about the stresses of working with seriously mentally ill people, and it just became clear to me that certain care managers, out of no lack of training or good intention, just are really being drained as a result of some of the ways we're tempted to help. And so this webinar is a chance to think about healthier helping, and I'll even use the term healthy detachment. Some of these consumers are people that can really eat up a lot of energy. Again, I experienced in Winston and talking to people how this impacts care managers. As I've talked to champions around the state, they're concerned about how it affects their frontline people. And again, my hope is that a little additional support, understanding how behavioral health can help you, and maybe refining your clinical skills can help limit how draining this is. Again, I think it's going to be behavioral health consumers are going to be part of what you do in CCNC, but maybe these tools can help limit how problematic it becomes. For those of you who joined late, let me just say we've got everybody on mute, but there's a chat box there at the bottom if you've got questions. If you need any help, that's the point of the chat function. You can chat with me or Chad Stage, or say hello to other people. So there's your definition of personality. I think you probably understand. I think what's critical here, if I were to take a highlighter, ingrained, enduring patterns. When we talk about personality disorder, character disorders, what I often say when I'm being glib in training is these are long-standing problematic behaviors that have been, when I say how do I know I'm dealing with a personality disorder, this person's been living this way a really long time. They're pretty entrenched in that way of feeling, behaving, thinking, and it's something that's deeply entrenched and therefore not easily treated. I don't want to be pessimistic. There are people with personality disorders who get better, but it's really important to understand when you look at this that for some of the people we're talking about, no amount of TLC, no amount of tough love is going to fix or change. This is essentially the essence of who people are, personality traits. Just a little bit about psychiatric diagnoses, again, just so you understand language that the behavioral health people use that you can understand. We talk about mood disorders or affective disorders. These all relate to emotion. The most common are depression, anxiety, relating to emotional states. It's important to note that there is a biochemical interaction. One of the things I feel strongly about is emphasizing that when people have been depressed for a period of time, there are biochemical changes that occur. The brain chemistry changes. And so that for some of our individuals facing depression, it's not just get out and do Zumba or do affirmations, but that the neurological changes, the biochemical changes in the body have made the mood disorder as long-standing and mean that the treatment interventions are that much more indicated to include psychotherapeutic drugs. So mood disorders, thought disorders, basically, as you'd suggest, problems with thought processes, how we think. And again, when we talk about schizophrenia, some of the other more serious thought disorders, these are also neurochemical. There's a biological difference. The MRI technology is going to show brain difference when someone has a thought disorder. Again, schizophrenia being probably the most common thought disorder, although there is an environmental component. And the last cluster, really the focus of what we're going to talk about today, personality disorders, the essence of who we are, behind the scenes wiring is the language here. inner landscape. What I haven't said, and I should have with apologies, this slide deck we got through the CCNC headquarters, and actually the behavioral health staff in Lower Cape Fear initially did this. So this is adapted from something that was done by the folks at Lower Cape Fear. So my apologies to the behavioral health staff down there, and thanks for sharing. So again, mood, thought, personality, there are your examples. Again, I think depression, the most commonly occurring mood disorder, thought disorder, again, schizophrenia, psychosis, any inability to, altering of reality, impairment in acknowledging reality is what I'd think of as thought disorder. And personality disorders, or personality is off there. So that's a bit to give you some background, and then I want to ask people to invite any conversation in the chat box. If you've got anything, I've got an eye there if you need anything. Personality disorders, it's important to note that there can be traits that aren't diagnostic of a personality disorder. So in other words, somebody may be a bit narcissistic and a little self-absorbed, but they don't have all the diagnostic criteria that would diagnose them as having a personality disorder. And so it's important, and again, it's not important for care managers to tease this out, but as you're working with your behavioral health support to sort of tease out the difference between style of being and a true definition of a personality disorder. We're going to talk today about clusters of personality disorders. This slide deck does an excellent job of inviting us to think about personality disorders that lump together in what are called clusters. Again, because of the similarities within the clusters, it's almost for care managers not important that you be able to split hairs, and oftentimes, depending on the nature of the disorder, it may be kind of tough to decide which of the disorders, but you get the idea that they're in a certain cluster of symptoms. Again, these personality disorders cause significant disruption in relationships to care managers, with healthcare providers, almost without exception. These are people that are going to be flagged as difficult people by the primary care providers that we're supporting, and so this tension between patients, primary care, the maladaptive behaviors, and often many of the personality disorders have problematic relationships. So we're not only talking about problems in healthcare delivery, but marital discord, family discord, other characteristics of relationship disruption, also part of the pattern. Remember, everybody has a personality. Some are working more functionally than others. And the caution here about labeling people, and what you'll see in a later slide, is patients are never helped by our labeling. You have a personality disorder. This just gives us a shorthand to explain to one another, to invite help from our behavioral health support, a kind of shorthand to describe a cluster of traits that would be called personality disorders. Let me check in and invite any comment or questions so far. If everybody looks at your screen down there in the chat function, any questions so far with what I've covered, any background information, if you'd put that in the chat function down there, anything you want clear before I'm going. The rest of the time I'm going to go specifically into description of the disorders and a bit about how care managers can respond, a bit about treatment. Any questions so far? Chat, keep an eye on that for me.
Sure.
I'm going to move forward then, but bear in mind the chat box is open. I do want to make sure that if you have questions that I have a chance to make sure you get those answered. So like I said, the rest of what I want to do is really talk about types. I'll go through the 3 clusters and then talk a bit about treatment interventions, about how the clusters are treated. Mostly what I want you to take away are some reminders about how care managers can manage these challenging situations. What we also should have said is most of you who pre-registered for this should have a hard copy or should have electronic copy of these slides. If you didn't get that, if you'll go to the chat function and let Chad Stage know. Chad, if you wouldn't mind typing in the chat function your email address, if you want these before or after, if you'll email Chad, he'll be happy to get you a copy of these. So again, 3 clusters, A, B, and C. Cluster A, the odd eccentrics. We've all had the odd eccentric. This is a consumer living off the grid a bit. Often people tell me about people living way, way out of town, sort of hanging out on their own, no social support, fairly limited social support, difficult to engage with the case manager, not really wanting what we're selling, certainly avoidant of the relationship that were offered. Again, the solitary, don't like being included. Often these are people whose families are estranged, want to be left alone, homeless, drifters, misunderstood, holed up in their trailer out in some holler, maybe electricity, maybe running water, but no significant interactions, and probably most likely only interacting with healthcare out of real necessity. These are not people that are doing preventive care. These are people that go to the healthcare, that receive healthcare when they absolutely have to. Next, in the cluster A, the paranoid personalities. Again, not uncommon. These would be people who would probably not show up on our caseloads very often. Again, you'll see some similarities in terms of avoidance of friendship, relationship. Hypersensitive, the paranoia means I'm questioning your motives, very suspicious. These people are very reluctant to join healthcare. So we probably would be even less likely to see a paranoid personality. Again, unless there's absolute medical necessity. These people, because of the suspicious nature of their disorder, they'd be very unlikely to be part of healthcare. Again, would only interact with us in a peripheral way. Maybe people we'd see as a result of a pretty serious, acute physical problem. The last reminder down there, we use the word oddballs. There's a clinical term. Schizotypal personality disorders. Again, this is that kind of odd person there. This is always the person that finds me at the Dollar General, wandering around, acting odd. Again, not comfortable with other people. This is again, think of the kind of marginally housed, not good hygiene, usually quite detached from everybody. Again, not with paranoia as the central feature. Again, we're differentiating here. The schizoid just relates to an avoidance of people. The paranoia really refers to some specific suspicious thinking. You're out to get me. The government is out to get me. The hospital keeps records of me. My television set is recording things. Those kinds of disorders, odd, peculiar. There you have it. So the cluster A disorders, again, not likely to be seen very often in care management. Again, if they're in an acute situation, they're going to be seen by us in the hospital, in the ED, because of an acute circumstance. They're not going to want to engage with care managers for the most part. After that, these are people we chase, people who seem avoidant of us. A thought about how to engage is being mindful about the limitations of threats and consequences. That especially if I'm avoidant of people, especially if I have a bit of paranoia, if my care manager comes across, you've got to do this thing, or X services will be pulled, or whatever the consequences of not complying with treatment, you're not going to make engagement happen. These are very difficult people to engage with anyway, and anybody who has a chance is going to have, I think, to have to emphasize a kind of compassionate, friendly demeanor. Again, one way to engage these folks is with discrete services. So these are people for whom, if a consumer wants a particular medical device or particular kind of service, that they're going to be more interested in interacting with care managers because of the stuff we can do, rather than wanting a friend or a shoulder to cry on or an interpersonal connection. So as you're thinking about how do I engage that chap out there in the woods who seems to not want anything to do with anybody, it's not going to be what a kind, caring case manager you are. It really is listening for some service, listening for something that consumer wants. I think what's really important is that you not crowd these people. If they're paranoid, avoidant kind of folks, know their limits. Don't crowd people. If somebody says, don't come on my porch, please do not go on their porch. And again, because of the nature of their disorder, these are the ideal candidates for self-management. Again, depending on their cognitive functioning, depending on their ability to take care of their health problem. They don't want us coming around. They don't want us calling. And so the idea that giving them some tools, giving them some encouragement, giving them some teaching, they're likely to become self-managers is the good news, the good part of working with Cluster A kinds of folks. The next cluster of folks, I think, are eating up 80% of the care manager's energy that I'm working with. That when people talk about the really difficult people that we work with, they're here in the cluster B, dramatic, emotional, erratic. These are the people, I always say, prone to emotion, screaming, firing healthcare workers, too much eye makeup, odd caftan, running around the county acting a little eccentric, shall we say. Again, antisocial personality is one of the three we start with under cluster B. These are typically sociopaths, people who don't. That means people who really inherently don't really have concern about others. I think the hallmark is violating others' rights without caring. So they've done hurtful things in the past. They're deliberately and mean-spirited, or they do harm without any conscience. To me, that's what this is about. They look to exploit people and situations, whatever actions are necessary to get their needs met. One caution I put forward here is, and again, this isn't for most care managers to point out, but one of the differential diagnosis things to consider is most substance users with whom I've worked who are seriously using substances tend to have some of these traits. And so teasing out whether what you've got is an active addict, alcoholic, or whether what you truly have is a personality disorder. Addiction, individuals with addiction are driven to act in antisocial ways. Persons with an antisocial personality disorder are wired to act in ways that are described on the slide. Borderline personality disorder, again, a significant percent of the challenging consumers have borderline personality traits. So if I think about who this is, it's inviting closeness, it's inviting dependency, it's the come closer, and then the rageful rejection of care management. Frantic, chaotic, inappropriate, highly emotional. Again, these are the people who have drama after drama, difficulty in relationships. Again, will often butter up a care manager, will often say, oh, well, you're the nicest care manager, unlike those 6 others or 8 others who preceded you. Always a clue that you're going to be the 9th or the 10th to be fired, just like the other ones. Blaming others, lack of ownership of their responsibility. And there can be aggression. I wouldn't expect violence typically, but aggression certainly in terms of discord in relationships. That what's central to the borderline personality is discord in relationships. Narcissistic personality here, the final cluster B type, not surprising, it's all about them. You think about what the term narcissism means. Not surprising that it would be somebody who doesn't really seem to have any real interest, grandiose, self-centered. Everything revolving around themselves. What's tricky down there, that last sentence, sometimes there can be some charming narcissists in the world. Again, not because they want a relationship, only to suck us in to what the service of their ego, the service of their needs. Oh, I'm sorry, there was one more, the hysterical personality disorder, and it's really difficult to tease these out. Drama queens, there you have it, overly dramatic. Again, especially hysterical, borderline, and narcissistic personalities. These are very difficult differential diagnosis. The good news is the treatment indications are fairly similar, and certainly the ways in which care managers protect themselves are also very similar. So again, hysterical, overly emotional, inappropriately emotional, again, there's this warmth, kind of engaging. They can be the life of the party kind of patient, but eventually dependent, needy, and intensely overdramatic and irrational outbursts, the hallmark of the histrionic or hysterical personality. So what do we do with these cluster B folks? The good news is there are treatment modalities available. It's intensive therapy to get people. Basically, people have to be able to take responsibility, first of all, and to try to recognize ways in which their current way of coping isn't working for them in the world. So we're not talking about the person who keeps blaming other people, but that eventually somebody sees a crack in their defenses enough so that they can say, wow, this is getting in the way of my getting what I need in the world and getting in the need of what I want. So that's where the possibility. Every once in a while, some short-term hospitalization, especially with your borderline personalities, there can be some self-harming that becomes part of that. Psychotropic drugs sometimes used, not generally indicated. Really, the longer-term treatment of choice is down there. Dialectic behavioral therapy, this very structured cognitive behavioral approach in which people who are engaged work with trained therapists on changing their thinking, changing their behavior, changing their emotional response to the cues that come up. The last reminder down there is that it'll be important in working with the cluster B traits to recognize that if there's any underlying depression or anxiety or obsessive compulsive traits, that sometimes treating those may be one part of the tool, to help alleviate some of the symptoms. If I'm sounding not especially optimistic, I think most behavioral health people will tell you there aren't a lot of people with personality disorders, and certainly the cluster B disorders, who get better. There just isn't, it's uncommon that people are taking responsibility and that people are figuring out that their behavior is no longer working. And in fact, many of the cluster B people live most of their life blaming others, blaming the primary care provider, blaming the care management system, blaming their parents, blaming whomever, blaming their landlord, blaming their siblings, instead of taking personal responsibility. So anxious, fearful, the last cluster, again, this will make sense. Again, people that wouldn't be too likely to show up in our care management, people that would be certainly hard to engage. The avoidant personality disorder, somebody uncomfortable in most social situations, withdrawn, fearful, sort of wanting to fit in down there at the bottom, but loneliness, lack of connection, and real limitations in terms of work. Obviously, you think about this cluster, somebody who really avoids social contact. It's going to be the person who cleans an office building after dark or something else, but for whom regular vocation during the day with other real human beings is not very likely. So dependent personality, folks, these are people that are going to be on our caseload. And again, sometimes teasing out the dependent personality with the hysterical and borderline personalities is splitting hairs for the behavioral health people. These are people who are unable to function without without other people caring for them. Inappropriately submissive, too quick to bond with the care manager, too needy, unrealistic needs. And again, what's difficult is if we're not mindful, these people attach to care managers and make it really difficult to have anything that looks like empowerment or self-management. And in fact, we only become sort of yet another source of dependency needs. We don't really ever help people by just fostering dependency. Obsessive compulsive personality, again, many of us know people that have obsessive compulsive traits. Again, the hallmark of the personality disorder: rigid, only my way of seeing things, single-minded, inflexible, preoccupied, as you might imagine, with details. They miss the big picture. Again, this would be the kind of vigilant, maybe hypochondriacal patient. I'm thinking about people that are tracking their intake and output or monitoring for side effects, overly concerned about side effects, maybe hoarders, maybe stubborn, rigid if they're confronted. And again, they're people who, as a care manager, can drive us crazy with their, potentially, with their attention to detail, with their correcting us, and with their perfectionism. So what do we do with the cluster C personality types? I think what's really important there is that recognizing that with people that have avoidant personality that are in need to make relationships or sort of rescue patients is really counterindicated. If there's an avoidance, there's inherently a sense that people don't want to be crowded or rushed by us. What I suggest in this slide is that we focus on what that patient believes might be helpful in terms of what we're selling, what it is that they want to have more of or less of. Their perceived benefits is where we're going to get some traction. This next bullet probably is the most important thing in the whole slide deck. Manage our unhealthy helping. When I teach this in real time, what I often talk about is most of us come to healthcare because we want to save the world and want to fix everything. And unfortunately, with particularly your dependent and your cluster B personality types, it will only make the patient more dependent. It will only make our life harder. And the goal I suggest is trying for what I call healthy detachment. When I say healthy detachment, it's an Al-Anon term. It comes from the addiction field. Some of you probably know a bit about the need for healthy detachment. In other words, the capacity to care about our patients in ways that still allow us to keep our emotional distance and our own well-being intact. Firm boundaries, emphasizing self-management for people who are dependent, no matter how much people lean on us and tell me what to do and tell me what to make for supper and tell me. Avoiding taking the hook, because buying into their dependency seeking only means we grow deeper into our relationship of being the source of their sustained dependence. With obsessive patients, there are ways in which you can use their organizing skills to manage their health care, but what's important here is avoid power struggles. You're never going to win a power struggle with these folks. So what I suggest is give control where you can. In other words, let's say medication is ordered twice a day. Work with your patient to let them pick what's right for them, rather than saying you need to be on a certain schedule. And try not to catch your patient's anxiety. I tend to get anxious when I'm with anxious, obsessive people. I talk faster, my heart is racing, my speech is pressured, and so I think this is as much a reminder as anybody, for me as for anybody else, that it's never helpful to become anxious alongside your patient. Don't count on logic. You know, again, if I have an obsessive personality disorder, your idea to say, well, that's not a very rational fear. We've all tried to talk to somebody about what we perceive as the irrational nature of their fear. But if they believe it, if it's wedded in their consciousness, especially this kind of rigid, obsessive person. It's not, logic is not going to break through. There's no aha moment there where people say, oh, you're right, I'm being obsessive compulsive. The last reminder down there is just about a caution about benzodiazepines and the other anti-anxiety medication. Certainly they have a role with anxious people, with obsessive compulsive people. However, I've seen enough misuse of benzodiazepines in particular, most of the anti-anxiety medications, to not put a caution that says dependence is always in my mind and the potential for misuse is always there. Let me catch my breath. That's a description of the 3 clusters and some suggestions. Let me invite people into the chat function down at the bottom of your screen. If you've got any comment or question, if you'll take that to the chat box. Any comment about, again, I've given a real broad overarching, this is a social work degree in an hour, but I just wanted to give you a flavor of the cluster, some broad strokes, and some broad strokes about interventions with those types of disorders. Anything I can clear up? Any questions? Looking at the chat box. Well, we'll watch it one more time. Chad, keep an eye on it with me. And what I want to do is sort of talk about what care managers can do. Again, the point of this webinar was not to have you able to diagnose psychiatric illness, but rather to have you think about what can you do as care managers. I think the first is to understand your capacity to screen and get support for yourself. That I don't think most of the care managers in the system need to or have the capacity to treat mental health disorders, but this gives you some shorthand to talk to your behavioral health support and say, wow, I was on that webinar, we talked about those cluster B traits, you've got these slides to refer back to. This person feels sort of avoidant, and I wonder what I need to do about that. I'm trying to be a good care manager, I'm trying to engage this patient, I'm trying to help them make a change. Listening, tracking the cues with your challenging consumers, being able to get additional assistance in developing a plan of care is part of what I hope people can take away from this conversation. For most people, our goal would be intensive outpatient therapy. It doesn't mean everybody wants it. It doesn't mean that people are even going to request that. But as anybody who's presenting with this deeply ingrained cluster of symptoms, for the most part, the only way people get better is fairly intensive psychotherapy, individual or group. The DBT intervention is often done in a group setting and can be very effective as a group intervention. But just to keep in mind, people with personality disorders don't go into any kind of remission, rarely get better on their own, rarely get better if we ignore it. This next to the last bullet really, again, is this has been prompted by the struggles I see the people in Winston-Salem going through, that part of the goal is not treating people, is not necessarily even being able to diagnose people. It's to understand and develop your radar to the point where you can conserve your energy and your time. It doesn't mean that we don't make an attempt to engage consumers. It doesn't mean we don't try to find some discrepancy between something they've said they wanted and the consequences of their current choices. That absolutely we use our MI skills with these people to try to build readiness. What I've said often, and I'll say to any supervisor that is willing to hear it, I do think that we probably in CCNC across the state spend too much time and too much energy pursuing the needs of people who really don't have a very strong likelihood of getting better from their mental health disorders, and for whom the likelihood of complying with the care management plan is really deeply affected by their lack of attention to their behavioral health problems. So knowing about how to conserve your resources, so the third time, the fifth time, the seventh time this person shows up on your call sheet, you are making informed choices that recognize we all have limits, and that conserving those resources is often good health too. The last reminder is just that you document what's going on so that you can know. The other thing that happens, these people frequently are in and out of the system or picked up by other care managers. If you've documented what's going on, documented any behavioral health consultation, your documentation of what the patient is doing, of how that relates to their larger psychiatric history is helpful for anybody who picks up that record. And what I'm thinking of in particular is if you've made mistakes, if you've had difficulty with the consumer, your ability to flag that and let me know about that, so that if I pick that same patient up, whatever you've done previously has been noted in their record. Again, link with therapy. What you want to do is look at how what you offer is inconsistent with what they want. So trying to identify the patterns that get in the way of our goals, naming that out loud, and then assessing our patient's readiness. That in other words, before we go very far into making a plan of care, somebody has to be at least contemplating making a change, must express some ambivalence about the choices they're currently making. So asking about how their behavior is helping them get what they want, exploring consequences by asking, is there anything about doing X that they don't like? And we may not use these questions exactly, but in order for somebody to make a change, in order for somebody to make a shift, there has to be, if I'm still blaming my ex-wife, if I'm still blaming the PCP of 10 years ago, my likelihood of getting better, doing anything differently is not great. So I'm listening for somebody's readiness so that I can offer the possibility of something else. I think it's really important that as care managers we say there are other ways to live. I think you can learn some other ways. I think it's important to remind ourselves that sometimes people do get better, even though that's not most likely the most common scenario. Offer the referral to someone, and again, this is a patient's identified something that's not working. We link our referral to a provider by saying this is someone who can help you with that thing that you've identified as not working. Reinforcing the consequence, perhaps it's the isolation, perhaps it's the economic, perhaps it's absence of connection to family, whatever it is, reinforce the consequence and make sure that they hear a consequence that they've said, not something that you believe. And a caution there, don't always assume that their impact on others is going to be the motivator. Certainly we talk about the narcissistic and avoidant personality type. Certainly the narcissist or the borderline personality traits inherently, by definition, don't really care about how what I've done has affected anybody else. And so we think of that as a motivator. Well, with many of these consumers, it's not going to be a motivator. So difficult to cure. However, there's a possibility of some insight. There's some possibility of patient teaching. Again, my primary goal is so that we as care managers can modify our behavior and hopefully conserve resources. Other suggestions here, diagnostic testing. This is obviously done outside of the scope of what we do generally in CCNC. A particular diagnostic test, the Minnesota Multiphasic Personality Inventory, MMPI, one of the most common paper and pencil tools. DBT, again, intensive. That's when we talk about intensive outpatient therapy, 2 to 3 times a week. It's really serious, intensive, but necessary, particularly if you're cluster B people are going to get any better. They need that level of support. How do care managers protect themselves? And I think most care managers on the call should probably blow this slide up, put it above your computer. Kindly redirect is the first reminder. Again, one of the things that wears our energy is somebody who's still wagging on and on about how terrible DSS was, or how terrible their probation officer was, or how terrible whomever was, and making sure that we are actively listening, but also using our open-ended questions to say, I wonder if we could go back and talk about, because for us, it's never helpful to get caught in that cycle of a patient's story. For most patients, it's not helpful to keep reiterating their story again and again. Manage our rescuing and encourage responsibility. Again, I know for many of us, TLC and wanting to help people is the best part of why we came to healthcare. It's a two-edged sword with these people, because they can almost smell our TLC coming, and again, in terms of weaning a dependent person, in terms of not getting drawn into some of the drama of our cluster B personality disorders, really some healthy detachment, giving people responsibilities for their own lives is great prevention. Clear, respectful boundaries. Here's what I can do, here's what I can't do. Again, many of our personality disorders come to us with unrealistic expectations of what care management is, and so being mindful of that. And again, one of the other things that's really important is keeping focused on the healthcare agenda, that some of these consumers are likely to take us down a primrose path of domestic violence and marital discord and whatever else, and recognizing, I think in particular, hysterical and borderline personalities. Bear in mind, every time you pick up the phone or go out to visit with people, our job is about healthcare. So redirecting back, I can't help you with your marital stuff, I can't help you with this. This is about, our relationship is about managing your diabetes more successfully, and being understanding that that helps you, and ultimately that helps your consumer. If you get drawn into the quagmire of all their complaints and set up an expectation that they're going to be able to lean on you for domestic violence counseling and legal advice and whatever else, really creates a potential for, I think, some real disruption. Being mindful of consequences in a way that's not punitive. I think what's important is sometimes we talk about consequences in a way that's threatening. I don't know that that's ever respectful or helpful. I often add reminding people of consequences in a matter-of-fact way. Certainly if we talk about your paranoid and avoidant personalities, being able to manage how threatening you're perceived is going to be critical to help them understand and incorporate the consequence. Try to develop relationships with their mental health provider. There in quotes it says, or your mental health provider. Probably most of us could benefit from a little more whatever else, but recognizing that link between behavioral health care, especially if it's an outside provider, and what we offer inside is critical. Work with your behavioral health team. Those of you in Winston are lucky to have Chad, one of the great ones in the whole state. Most everybody I know has behavioral health support. I know it's limited. Everywhere I go, it's limited in terms of how much is available, but they are there as a resource, if nothing else, to tell us that we're not crazy, and recognizing, again, the challenges of how long-standing and difficult it can be for these consumers to change their behavior. That's what we wanted to do. Chad, let me check in with you. Unmute yourself. Anything I've missed in terms of strategies to protect oneself? Anything you want to emphasize for your staff? Anybody else who's listening?
Yes, I mean, I think you covered it very well. I think the big thing that I would want the care managers to really be cognizant of going forward is that these are difficult patients. And if you don't take care of yourself, they will drain you and make you extremely, they're just very exhausting patients to work with. And, like Jim said, I'm here if you come across one of these patients and just need to vent or, maybe some guidance on how to proceed. I'm more than willing to, take the time to talk to you and offer you that ear that I think sometimes working with these patients, you just need to vent. And so I'm here.
Great.
Really appreciate it, Jim. I think that was a great presentation.
Yeah, and thanks again to the people at Lower Cape Fear who gave it to Amelia, who let it be loaned out. Are there any questions? I've included my email in the chat box. You've got Chad's email if you need the slides. If you didn't get an advanced copy of the slides, please get a hold of Chad. We've still got time for any questions, any comment there in the chat box. You can private me or to everybody. Anything that people want to add or ask before we wind down. This is being archived. Anybody in the Northwest system, there's an archive of this, and your peers who couldn't be on this
And Jim, I think
will have access to archived version of this. Any final thoughts?
I would
questions?
add that we're probably going to be putting this onto our YouTube channel. So for those of you that aren't Northwest employees, I will send a link to where you can watch it when we get it uploaded.
Great. Well, with that, I'm just going to thank Chad for giving me this chance. Again, thanks to the folks at Lower Cape Fear on the behavioral health team for sharing this information that I was able to adapt a bit. Folks in Winston, I'll look forward to seeing you next month. Everybody else, if there's anything Chad or I can do to help, certainly make sure your champions know about this resource. I'm happy to share the slides with any of the champions. They all know how to find me. I've been with them, most of them, for several years. So with that, not seeing any questions, I'll just invite people to enjoy the rest of the day. And thanks again for making time. I hope there's something you can take away from this that'll be helpful. Have a good day.
Thank you all.